Hey everyone, it's Professor Walden, and I thought, why not do a little bit of learning with me, okay? So with that being said, I've got something to present to you, and I am really, really excited about it. If you're interested in learning more, join me over at my website. This is mainly for those who are nurse practitioners who are about to pass their board exams. I'm really excited about it. It kind of gives you a little bit of a teaser as to what to expect when you are learning with me through my programs, and I have a lot of them for you to choose from. So here's your first sample. Let's learn some psych together. Let's do it. All right, see you soon. So let's start off with psych. And starting off with psych for the purposes of your exam is you guys, you're really not going to get a whole lot of psych information. The psych information is going to feel very generalistic and very basic. And why is that? Because we have a psych exam. And typically all that you do in practice is very surface level psych. But there are some aspects that you will need to know for the purposes of your exam, starting with the mini mental exam. Let's talk about what that is, why you see it, and its purpose, okay? So what that is, the mini mental exam, the MMSE, you guys all know what this is, especially when you were in clinicals and you were taking care of those 65 and older patients, or as I like to refer to them, your Medicare patients, right? Because that's essentially when you start doing this. The MMSE is a cognitive assessment. It is useful in testing for cognitive impairment, okay? So what we are looking for is a deficiency in knowledge, in thought process, in judgment. You guys know this clinical screening tool because this is when you used to ask the 65 and older population to draw a clock and make it say 11 o'clock. And you were literally giving them 5 minutes, however many minutes, and you are asking them to do that and seeing if they can do it. If they are unable to do that, that is a thought process, a knowledge impairment, which could lead to mean we need to investigate why they are having that issue. And obviously, we tend to use this leading towards dementia, all of that good stuff. So those are the things that we absolutely want to look at. It is short. It is efficient, it is well researched, and that's why we use it. You couple that with good history and physical exam, some good labs, you're gonna realize whether or not your patient is headed down that dementia pathway or if there is something medical that's going on that you need to address, okay? This typically takes less than 10 minutes to administer. Now, you're probably like, well, I remember doing something like this, but it was a little bit different. Maybe they called it the mini cog. What you are looking for are the same things, but there are absolutely different versions of this exam. Why are some people using the mini cog and the MMSE or the MMSE? It's copyright laws. Technically, they have to pay for this stuff. Like offices are supposed to pay for this. But you and I both know they're probably just copying it and handing you a sheet of paper or it's built into the system. But that is why you see this. This is gold standard for the assessment, for the cognitive assessment, okay? MMSE is gold standard. So again, for the purposes of your exam, this test for cognitive impairment, you are looking for a deficiency in knowledge, thought process, and or judgment, okay? It is quick, fast, and well-researched. And moving to the next part of psych, let's talk a little bit about benzodiazepines. And benzos get a really bad rap because y'all know in the last few years, y'all have definitely seen them on the news and you're probably like, and everyone's telling you not to prescribe them, right? But why do we use benzos? We use them for anxiety disorders, insomnia, epilepsy, any kind of spasticity disorders with muscles, seizure, like we use them for a lot of reasons, right? So they do have good properties. The problem is at one point, providers were overusing them, and that's everybody. I mean, physicians, NPs, PAs, all of us. We were over prescribing them, which then, of course, added to the addiction scene, right? So that's why we had an issue. So when I talk about benzos for the purposes of your exam, I'm specifically referring to meds like Xanax and Ativan, because those are the benzos that you are likely going to see referred to on your exam. Why we don't like benzos, or why they get such a bad rap, is because they act on the CNS system, right? The central nervous system. And especially for our elderly, we don't like things that act on the central nervous system, okay? Why is that? Because that's the system that's going to cause respiratory depression, or they're going to go into arrest. Your patient's going to stop breathing, okay? They're going to get drowsy. They're going to get confused. They are going to have syncope. All of that, when you talk about elderly people, leads to a fall, okay? We don't like that, right? We all know that if our patient falls, that's a bad deal, especially for our elderly. They don't tend to make it. They don't tend to come back out of the hospital if they fall and break something. So it's not something that we want to encourage, and why it's heavily discouraged when we talk about giving benzos to our elderly, okay? Now, the same things can happen to younger folks, right? Like the same situations, and also potentially because we will abuse them as younger folks. Older folks will abuse it as well, but we have a propensity, obviously, because there's more of us, we will abuse it in higher numbers, okay? So that is the concern with benzos. Now, let's say that NP Marshall, that you inherit a patient who is on benzos, because that does happen. We are all going to go to work, and we are all going to inherit patients who have who are going to be on benzos, and you want to get them off of it. The thing that you need to remember is that you just want to wean them off of it. So wean, titrate, because you're a board exam, they love different words, okay? So wean, titrate, any of that kind of wording that means slowly remove them off of the medication, that is what you are going to want to be aware of and look for in your answers on the exam, okay? So just be very clear about that. There are going to be points at which I move through this, and I'm going to be saying different words for that very reason, because you just want to, again, start getting being real aware of what the words means and using synonyms, because we like that on this exam. All right, so let's talk a little bit about psych meds, right? So let's talk a little bit about psych meds. Now, when we first talk about psych meds, one of the things that we absolutely want to talk about, let's talk about the half-life, okay? Okay, so one thing that you are going to realize about Professor Walden, if you have not already realized it, is that sometimes I don't know how to say these words. I'm very honest about it. Please don't mistake that for that I don't know what I'm talking about, because I do. It is simply because I read a lot. And so a lot of the information that I receive is from reading. And of course, everybody knows when you read a lot, you don't always pronounce words correctly in your head. That's just natural. Secondly is, I can't spell worth of nothing, and I will mess up the simplest of words. So thank God for a spell check. Okay, so y'all don't judge me as I go through this and I am writing and I'm like, oh crap, I spelled that wrong. Just roll with me, okay? But I promise I am telling you absolutely the right information. All right, so with that being said, the half-life of these drugs, it's an important part that you need to be aware of for your exam. So the half-life of a drug is the time that it takes for the amount of drug's active substance to reduce by half, okay? So where's my pen? There we go. So let's say for the active substance to reduce by 1/2, okay? That is what we mean when we refer to the half-life of a drug, because that active substance is the good stuff that has the happy part of the drug in it that makes you feel better, okay? So now with that being said, for the purposes of your exam, which drug has the longest half-life? Which drug do you think that is? I'm just gonna be writing it. Fluoxetine. Fluoxetine has the longest half-life of any psych med. We know fluoxetine as Prozac. Yes, okay. I am going to talk about meds a little bit later, so don't worry about generic and all of that good stuff. Don't worry about it. But fluoxetine, otherwise known as Prozac, okay, 4 to 6 days. 4 to 6 days is the length of the half-life for this particular drug. That is really long. And why is this important? This is important because that active substance refers to how patients feel when they start to withdraw off a med. So you've ever had a patient who says, I missed my meds today and I'm starting to feel real shaky. Like, is that a thing? I mean, I've been taking this med for, a year and I've missed one drug, like 1 day or 2 days. I shouldn't be feeling it, right? No, ma'am. No, sir. They probably are feeling it. And why are they feeling it? It's because their drug may or may not have a long half-life. Again, Prozac has a very long half-life. So our patients, which we don't encourage, our patients, if they do miss a day of Prozac, they are not typically going to feel any type of withdrawal symptoms. They're still going to feel just fine and like the drug is doing its thing. So the next day, you're just going to say, well, just remember to take your meds every day and keep on going. Now, let's flip that on its head. So the drug that has the shortest half-life, okay? The shortest half-life, paroxetine, okay? Otherwise known as Paxil, okay? Otherwise known as Paxil. Paxil has a half-life of only 21 hours. Now you see what I said about withdrawal symptoms? Think about that. Think about that. So 21 hours, this means your patient who is taking Paxil, they are absolutely going to feel it, right? So they're going to be that patient who says, God, I missed my drug today. I feel a little bit like, ugh. Yes, okay? Yes, they probably are. So take them seriously because they probably are feeling that way because it only has 21 hours. They're starting to feel those withdrawal symptoms, okay? They will have the most pronounced withdrawal symptoms. So the shorter the half-life, the more pronounced the withdrawal symptoms will come on. Okay. And this is also very important when it comes to discontinuation of meds, right? And why we have to wean people and why it's so important. We tell people, please don't abruptly stop our drugs. Okay. It's important because of this. All right. So these are SSRIs. For the purpose of your exam, it's going to be very important, okay, that you understand that for a lot of the psych medications, and especially when you get to any of the psych questions, that a lot of the answers are going to be the classification of SSRIs, okay? So meaning, if they ask you a question that says, what is first-line treatment for depression? SSRI. What is first-line treatment for anxiety? An SSRI, okay? What is first-line treatment for PTSD? SSRI. These are all the answer options. So you really shouldn't get it wrong, okay? Do we have particular drugs that are favorites that we prefer for things? Absolutely. But for the most part, by and large, for the purposes of your exam, SSRIs are going to be the valid answer. The classification of the drug is going to be the valid answer. This is not an area where they love to be super specific. Okay, we've got those future areas, so follow us along for that. All right, but this is first-line treatment. SSRIs are first-line treatment for depression, anxiety, OCD, PTSD. Okay, so all of those things, your answer is going to be in the classifications of SSRIs. All right. Now we did mention Paxil, and so since I mentioned that, I would like to take a moment and talk about Paxil. I think at this point, everybody understands that Paxil causes erectile dysfunction for men. But what I don't think most people understand is that all of the SSRIs and even the SNRIs have some form of sexual dysfunction for both male and females, okay? So all of them have some kind of aspects. Some are worse than others, some are better than others. Why we mention Paxil is because Paxil is super common. It is one of the ones that typically all providers know, especially in our men. It might cause it to not get up. I mean, that's just what it is. And so we have to be very honest with our patients about that and listen to them. And again, ask the questions about sex, because a sexual patient is a happy patient. You have a man that's unable to have sex with his partner. He's not going to be happy about that. He may be shy about discussing that with you, so you cannot be shy about it. Plus, we can fix this, okay? So we can fix this. So let's say you give your patient Paxil, you are talking to them, you know, a week or so later, how are you feeling? How's it going? And they bring up, yeah, I'm having some issues down there. It's not really working. And so you say, oh, okay, so let's talk about this. One of the things that you absolutely can do is you can change it. I mean, that's an easy one. But for the purposes of your exam, we all, I think, have realized that at this point, we can add Wellbutrin to it. So you keep the Paxil, add Wellbutrin. It kind of blocks off that mechanism that's causing that erectile dysfunction. Does it always work for everyone? No. But the research tells us, okay, because I'm always going to tell you based on the research tells us that most of the times that will work. Okay, so that will work. So just kind of be aware of that and make sure that you are addressing that and that you obviously are aware for the purposes of your exam. Let's also talk about the therapeutic range for lithium. Lithium is going to be one of those drugs that I'm just going to bring up because, again, you should be aware of it for the purposes of your exam. So I think, again, most of us, just because of even just the social media world and society, we understand that lithium is first-line treatment for bipolar. Like, we get that, right? So, and remember what bipolar is. Bipolar are those high highs and those low lows. So we will have periods of grandiosity as well as, you know, manic stages, and then we will kind of withdraw and go through what we feel or what people will feel like is a true depression, and they kind of get withdrawn from folks. Okay, so that's lithium. But what we need to understand with lithium is that it has a therapeutic range, and it is 0.6 to 1.2. That is the therapeutic range of lithium. Okay, so with that being said, what does that mean? We need to keep this steady state. If it goes above 1.2, what happens is your patient becomes toxic. Okay, that toxicity is starting to happen. Now, what does that look like, Professor Walden? When your patient starts appearing toxic off of lithium, they really honestly appear drunk. So they will start slurring. They may act and seem confused. As it progresses into a tremor, and they start to vomit, maybe even have some nausea and vomiting. So that's, you know, that's more towards the higher range of toxicity. But it definitely starts off with slurring and confusion, which can look like anything else. So you have to be very aware of that, even when you are talking to your patients. Hey, if this starts happening, I need you to come in to see me. Your first instinct should always be to stop the medication, right? We don't do any other action first if our patient is toxic. Our first action should be to stop. Okay, so we stop the med. Of course, then we can go through and do some testing and run labs and all of that kind of stuff. But if your patient is appearing toxic, the first thing you do is you stop that medication. All right, perfect. Now, oh, I always like to say, before I move on to the from the lithium, I love a good celebrity example, and we are going to kind of use that theme throughout here, okay? So with that being said, let's talk about atypical antipsychotics. So atypical antipsychotics, guys, there are 3 atypical antipsychotics that the gods above for the AANP and ANCC feel like you should know. Those atypical antipsychotics are Zyprexa, Risperdal, and Seroquel. You must know all of these, okay? So again, you don't need to know them individually, but just know collectively that these are the atypical antipsychotics. They just didn't fit in any particular category, which is why they call them atypical. Super smart, right? All right. So with that being said, these are what keep our patients safe. Okay. Now, a good celebrity example. Oh, let's talk. And it has to do with the bipolar as well. Our example is, of course, Kanye. Yes, Kanye West. All of us have watched this saga for the last several years, and you can't tell me that this patient or this child is not bipolar. He is literally textbook. Okay, he is textbook if you have been watching that saga and following along, even if you are following along at a distance. Okay, oftentimes a lot of our bipolar patients will actually have these antipsychotics also in the mix of their medications that they are taking on a while. Sometimes they do, sometimes they don't. It really depends on the patient. But however, for the atypical antipsychotics, why we need to watch them and why we need to be aware of them is because these atypical antipsychotics may trigger certain genes to turn on. For example, if you are predisposed to diabetes, it could trigger your diabetic gene to kind of kick on, and suddenly your patient will convert to being diabetes, whereas before they were not even concerned about that. It was not even on the radar. Or maybe they don't fully convert to diabetes. Maybe they just become insulin resistant. Okay, that too becomes a thing. That still affects your organs, that still will cause you to gain weight, and it still will make it difficult to lose weight. Okay, so that could be an action that happens as well. And this comes again from one or all of these atypical antipsychotics. At the end of the day, what it does is it starts to affect your cardiovascular system and your BMI. Okay, so it affects all of that. So your BMI, okay, I'm going to write all of that. So BMI, we have to be aware because it will blow them up. It will make them gain weight, okay? So this is something that we absolutely need to be aware of. So with the BMI, like I said, any kind of cardiovascular situation, you guys know that is the #1 killer for men and women, cardiovascular disease. So we have to be aware of what is starting to trigger those things. So when it starts affecting BMI, starts affecting anything cardiac, and that includes like hyperlipidemia, okay, and leaning into those metabolic syndromes where you have cardiovascular issues, BMI increasing, because that's what that BMI means, the BMI increasing, which will lead to obesity. And then you couple that with insulin resistance, you start getting this trifecta of metabolic diseases. Guys, you have to watch your patient, okay? So we're going to say BMI increasing here, okay? Cardiovascular, hyperlipidemia, okay? Demia. Yep, here we go. That also means their blood pressure, okay? That means all of that. So all of that stuff we have to be aware of, not to mention, like I said, diabetes or /insulin resistance, okay? So again, this is why we need to be aware of atypical antipsychotics. It's important, okay? It's important that we are aware of them, and that is why. Let's talk a little bit about ADD, ADHD, okay? Super common. We're starting to get a lot of late diagnoses, adult diagnosed ADHD. But inherently, ADD, ADHD, in particular ADHD, attention deficit hyperactivity disorder, it's a psych condition, right? And we're gonna reference it in reference to children because that's usually who it's diagnosed in first, but you and I both know that, again, we're getting a lot of adult diagnoses. So this is a psych condition, and it's largely recognized first in children. And so what is happening here is you're seeing levels of inattentiveness, hyperactivity, impulsivity. I had a patient one time, and this was during clinicals, where a child was brought in, and I tell you, that patient was like this in the lobby. just running through there. Y'all, at one point we saw the lights flickering off and on in the lobby. Why? Because the child had got up on the couch, got to the light switch, and was just on and off, on and off. This is classic. This is classic. ADD, ADHD, something's going on, right? So some inattentiveness, some hyperactivity, and some impulsivity. These folks are just, in general, they have a difficult time in kind of social interactions. Why we say this mainly kind of is seen in children is simply because they're usually seen in children in schools first. So usually the child is labeled in school first. And so this child who has these issues, they're usually labeled as what? A troublemaker. Okay. That is usually your child who has ADHD, because usually the teacher is seeing something, and the teacher is seeing some other things. What are they seeing? Well, some other hallmarks that may be seen is lack of focus, right? They have a hard time focusing on information, disorganization, right? So they have stuff everywhere. These are the kids whose desks are just looking like trash. Now, granted, every 8 and 9-year-old desk kind of looks like trash, right? But then you have some who really can't keep their folders together. I mean, no matter what you do, they have to be really, really structured, and that kind of helps them get through the day. They might have difficulty completing tasks, okay? So I'm just going to put difficulty finishing here, all right? Forgetful, losing things, all of that matters. If a child continuously talks over someone else and continuously interrupts someone, that too is potentially ADD or ADHD, okay? So there are a lot of things, and now you understand as we say this, why it's so apparent that we see it in school, because not only are children at school most of the day, but the teacher is going to see most of that because they're spending a lot of time with that child, right? And so they're going to see that. One of the things that the DSM says is that ADHD has to be identified in 2 places, okay? Identify, to diagnose, okay? 2 places, right? So that's the thing. So usually the teacher comes to the parent, I think I'm seeing something, something's going on. That's one. And so then the parent may take the child to the doctor, because that may be the suggestion, and say, okay, let's go ahead. Or they're coming to you in P. Hayden and saying, all right, the teacher mentioned this. I'm actually seeing this at home too. That's 2. They saw it at school and they saw it at home. That's valid. Okay, because the symptoms must be present in multiple settings, and the minimum multiple is 2. All right, so that is the requirement. So if someone comes and presents this, then you know, all right, that's what's going on. First and foremost, treatment is therapy. I know we're ready to throw children on medication so very quick, but quite frankly, you don't have to do that, okay? And it's not even you don't have to. This is guidelines state, okay? Because I'm always teaching you according to guidelines. Guidelines state that therapy is actually first-line treatment, cognitive therapy. And then we can also add medications if we need to. Some folks may need the medication. Some folks might do fine without. But for the purposes of your exam, you need to know both of them, right? So therapy plus meds is what we are going to say, because that's how the guidelines want you to work this as you guys go out and you start seeing patients. Therapy plus medications. All right, so now let's talk about those meds. We have 2 types, okay? 2 types of meds to treat this. We have stimulants and non-stimulants, right? You guys know which ones these are, because if you watched enough Law and Order, you know that folks like to have parties, folks meaning the teens like to have parties with the stimulants, or people just, again, abuse, overuse the stimulants. So with that being said, that is your Adderall, right? Your Adderall, Here we go. Adderall, Ritalin, Vyvanse, okay. That's an S, that's an S, okay. Vyvanse, those are your stimulants, okay. And so that is absolutely, potentially, and these are long-standing drugs. Like we've been using those for years, but there is a movement right now. What we are seeing is because we know that they are abused and overused and oftentimes stolen and sold. It's kind of like benzos. Like we kind of want to stop giving them, right? We want to stop giving that opportunity. So we're moving largely towards the non-stimulants. That does not mean that the stimulants are not as effective. That does not mean that at all. They are actually really effective, which is why we like them. However, because of that abuse potential, guidelines and kind of societal standards, we are moving away from using those. So one of the popular ones that we are starting to use is Strattera. Okay, that is a non-stimulant medication. If you overtake that or take that too much, there's no kind of abuse potential that happens. You don't crave the drug, which is why we like it. All right, so that is what we are looking at for ADHD. Okay, 2 places, identified in 2 places. First line treatment is therapy, then you can add meds. For the purposes of your exam, you may not see therapy as an answer options. I'm just going to let you know that because a lot of times on this exam, they want you to fix it with medication. So that's why we know that the first line treatments are these 2 types of drugs, the stimulants and the non-stimulants. Okay. All right. Let's talk a little bit now about some eating disorders. And we're going to first start with anorexia. Anorexia has a lot of buzzwords and keywords, right? So there's a lot of buzzwords and keywords associated with anorexia, but let's just talk about it in general. So anorexia nervosa is an eating disorder, and it is defined by restriction, okay? Restriction. So anorexia is the ones where people just absolutely will not eat. Okay, so that is anorexia. It is the one thing that they can control, so they will control it. And by controlling it, it is, I am not going to intake anything that is going to fill my body and make me look bigger than I think. Because of course, coupled with these eating disorders, there's a lot of body dysmorphia and things like that. So they're not going to ingest and risk seeing themselves in that type of manner. They have an intense fear of gaining weight, and the fear is so intense. And I don't want to call it irrational because it's someone's perspective, right? But it is so intense to them that it distorts how we regularly eat and just kind of live our lives. Okay, it becomes very, very serious. So now with that being said, let's talk about some buzzwords and some keywords that kind of go along with anorexia. So the things that you may see from your patients who are suffering from anorexia, you're going to see, okay, because these are some of the common ones, amenorrhea, but keep in mind, you're starting to see anorexia a lot in men and boys as well. So it is not just defined to women or thought to be just defined to women like it used to be. Okay, not anymore. So yes, it's amenorrhea, which means a stopping of the cycle. However, you're starting to see it in boys. So let's keep going so we can see the other things that you'll see. You'll see cold intolerance. Okay. That is an option. How about constipation? Everything slows down, right? So everything absolutely slows down. Let's go with edema, fatigue. Again, remember, food is an energy source at the end of the day. So if there is no energy in the body, I got no energy to do anything. So therefore, I am going to be fatigued. If there's no food in my body, there's nothing to poop out. So now I've got constipation, and we're talking, they're not even drinking water sometimes, guys. Okay. Some will, some won't. But at the end of the day, I need water in order to push the poop out. Okay. So that leads to the constipation as well. There's nothing in me. There's nothing to come out. Okay. As they lose their body mass, their muscle, and their fat, they become cold. Okay, that's what's happening. So let's kind of dig a little bit deeper into this edema. This edema, because there is low albumin. Key here. Okay, there is low albumin. Remember, albumin is just protein. Again, food is an energy source. So if I'm not intaking protein, what happens is the body starts holding onto fluids and sometimes it will even do things like third spacing, which is accumulating fluids in spaces that we can't easily access, basically, is the best way to put that. Or the simplest way to put that. But you will have low albumin, okay? So that just means, again, low protein. When you have that, you have edema, or more specifically, peripheral edema, okay? That's what happens. And so when I say peripheral edema, I mean face, hands, okay? Face, hands, lower extremities. That's usually how I do it. Face, hands, lower extremities. You'll see the puffiness in the eyes, definitely the swelling in the hands and the lower extremities. All right, so that's really what happens. But let's get into even some more buzzwords and keywords, right? So here we go. So we have all of that. They will experience, I'm going to put B for buzzword right here. So then we have linguo. That's that fine baby hair. Their body tends to start reverting, guys. That's exactly what's happening, okay? And they get that fine baby hair that you usually only see in those fresh newborns. Muscle wasting, that I think is self-explanatory, right? As your body eats the fat, trying to stay alive and keep the organs moving, well, sometimes it's eating all the fat. Now, where else are they going to get the energy from? Because again, you need energy to continue keeping your body moving, the heart beating, the brain working. So we eat the muscles, okay? So the body starts literally eating itself in order to stay alive, okay? Once you start seeing muscle wasting, you're starting to get into the extremities of anorexia. That's what makes them look super thin, because now they have no muscle tone as well. Also, obviously, with the obvious, low BMI, okay? That BMI is usually, oh, what in the world? There we go. Low BMI, and we're usually talking, less than 18. Okay, less than 18, 18.5, less than there, that is the BMI number that we are talking about. All right. So that is what you have to kind of be aware of. And those are kind of your keywords. So if you ever see a question that's starting to use these words, then you absolutely know that they are starting to talk about anorexia, and your mind needs to go to that file and you need to pull all of the information regarding anorexia so that you can answer the question appropriately. Okay. Now, of course, with both anorexia and bulimia, guys, the labs are just going to be trash. The labs are going to be red, high, low. Everything is going to be worn off and on. There is no specific lab that you can do that's going to verify that, oh, your patient has anorexia. That's not a thing, so we're not going to make it a thing. However, you're just going to use the labs as a guideline so you know how their body is functioning so that you can treat those appropriate things. Okay, so that's kind of what you are looking at there. And that goes for both, like I said, anorexia and bulimia. So no specifics in the lab issue as well. However, I do want to tell you that you are going to run everything. You're going to run an albumin. You're going to run a CBC, you're going to run a chem, you're going to run vitamin D, you're going to run hormonal labs because you got to see how their hormones are fluctuating. Thyroid labs, okay, because we may be affecting the thyroid as well. So you're going to run all of the labs. Again, they're going to look wild. They're going to be off-putting and just not looking appropriate, but you're ready for that, okay? And so you can start adding medications to fix those individual things. Now, with that being said, guys, first line treatment for anorexia. So let's go over here and let's see, anorexia treatment, okay? So with that being said, first line treatment for anorexia is just therapy. Yeah, there's no medications that can fix, quote unquote, anorexia. There's nothing approved that's going to help. A lot of it is happening up here. And so we have to address this for the patient. so that we can get them on their path to recovery. Okay, let's move to bulimia. So with bulimia, you know, I hate to even distinguish them like this, but bulimia, usually folks have a little bit more meat on their bones, okay? Anorexia, they are usually real thin, okay? But with bulimics, they tend to have a little bit more meat on their bones. Bulimia nervosa is a condition that is commonly, again, found in adolescent females. However, we are starting to find it very commonly held in men and women, so we can't even say that a lot of the times anymore, but it's characterized by the binge eating. Here we go, okay? So it is binge eating time. And when we say binge eating, we mean all the things. There's periods of we're not eating anything, and then suddenly we're eating all the things, okay? We are suddenly eating all of the things, and I do mean all of them. So sometimes that means, okay, guys, they may not have eaten, they come home and they feel that urge and they just open the fridge and eat what's ever in there. I have heard of folks eating whole cakes. I have heard of folks eating mayonnaise out the jar. I have heard of folks just creating whole meals. A lot of times there's no rhyme or reason to what they're eating. They're just eating it, okay? Then it's usually followed by inappropriate behavior, okay? So they're going to compensate. Usually it's the vomiting, the self-induced vomiting, right? So they're going to stick their fingers down their throat, go to the bathroom, and you're going to hear the vomiting in the bathroom. But also, not to say that anorexics don't do this as well, bulimics are the ones who typically, per the research, guys, and again, I am teaching you according to the research and the guidelines. Per the research, bulimics are the ones who are typically going to laxative use, diuretic use, do a lot of working out. Again, not to say that anorexics don't do this as well, but however, that is one of the areas where, yes, okay, you are going to start seeing more of that use. So the abuse of laxative drugs, diuretics, a lot of working out, okay? So let's kind of go through what you might see buzzwords, keywords for bulimia, okay? So here we go. I'm going to write buzzwords here, a circle of B right there. So again, what we're going to see is we are going to see a sore throat. You guys know where that's from, right? So a sore throat, that's absolutely from vomiting. Constantly have the acid kind of coming up into my throat, that's going to be an issue, right? So again, irregular cycle, if it is a female, okay? So irregular cycle, they too are going to be lethargic. Okay, that's going to be a thing. They're going to have abdominal pain, right? Bloating is also a big one. So those are kind of some of the things. One key thing that I want to mention here is that bulimics will have what they call Russell sign. Okay, Russell sign. Here we go. So what is Russell sign? So Russell sign is the calluses on the hand, and that's simply from sticking their fingers down their throat and vomiting, right? So that is exactly what that is. But the good part about this, according to our guidelines, there is first-line treatment for the treatment of bulimia. So yes, there is medication that we can use to treat bulimics. That is, ta-da, which we mentioned already, fluoxetine, right? So it is FDA approved to treat bulimia. Of course, don't forget therapy. Let's add that in because that's going to be important, right? So fluoxetine and therapy is going to be a thing. So you can use Prozac, because that is exactly what this is, and therapy are going to be important to kind of curb those urges. This is a long disease process. You have to be in it with your patients and in it for the fight, because it is going to take a good long while for them to really feel healthy and to kind of get back to quote unquote the normalcy. I hate using that word normal, because what is normal? But anyway, getting back to the normalcy of what society thinks normal should look like, okay? So perfect. So we have just gotten through psych. Psych, again, is usually fairly short. And what we're going to do next is we are going to move on to neurology, okay? Probably the only slide that you do not see is depression, right? So that's probably like, I don't see that. I don't see you talking about that. And simply because depression is depression. I think at this point, especially after COVID, we have all suffered from some type of depression. And as clinicians, we all know what that looks like. You are withdrawn. Sometimes your appetite kind of slows down, or it goes into overdrive. We're either not eating enough or we are eating too much. But we absolutely withdraw into ourselves. We disassociate, we disengage, which are not good things. Also think of your elderly patients, right? So your elderly patients typically, what depression looks like in them is they sleep a lot. Okay, so they sleep a lot. So you know those patients, Miss Smith down the street who's in the bed at 2 o'clock. That's the kind of stuff that we are looking for. And again, first line treatment for them for that is an SSRI. So that is what you're going to do. In my experience, what I have seen is that a lot of patients feel as if they, they're concerned, or I don't know if I want to take. I think it's, again, being more and more widely accepted. If you need help, you need help. Again, my thought process is you don't have to be on it for forever, but you just want to encourage your patients that this feeling like this is not a normal thing. First line treatment is an SSRI for the purposes of your exam, but also we need to process that through therapy, right? So we're going to also encourage, because that's what the guidelines say as well, that we need to encourage therapies in order to talk through so that we can develop good coping skills, because that's the key right there. All right, guys, let's move into neurology.